If you ask a patient to place their hand flat on a table and their ring finger just sort of remains hovering in the air, you aren't just looking at a simple hand cramp.
No, definitely not.
You're looking at a bizarre, Viking-linked genetic misfire where the body literally starts building the wrong kind of tissue. It warps the intricate architecture of the hand from the inside out. Welcome to this revision deep dive.
Glad to be here.
If you are joining us today, you are a resident preparing for board exams like the FRCS in plastic surgery. And our mission today is to give you a rapid-fire, high-yield mastery of Dupuytrens disease.
Right, because we are unpacking the pathology, the complex three-dimensional anatomy, and, the surgical management so you can understand exactly what is happening under the skin.
Exactly.
We are going to look past the surface symptoms today, because to truly understand how to fix this condition, you really have to explore the cellular mechanics that literally pull the fingers into the palm. I mean, this is a complex, benign fibroproliferative disease. It's got deep genetic roots and a very, very specific target demographic.
Okay, let's unpack this, because before we look at what actually happens inside the hand, we need to understand who gets this disease and why.
Yeah.
The demographic data points to a pretty fascinating genetic mystery. So who is actually walking into the clinic with this?
Well, the highest prevalence is unequivocally in Northern Europeans. Specifically, we're talking about patients of Scottish, Icelandic, or Norwegian descent.
The Viking connection.
Exactly, the Viking disease. So in the UK, the overall prevalence is about 4%, but look at what happens as the population ages. That number jumps dramatically.
Wait, how high does it go?
It hits 20% in patients over the age of 65.
Wow. Okay, so age is a massive factor for your exams. What about the sex distribution?
It is overall 3 times more common in males. However, and this is a key detail for your FRCS Viva after the age of 70, that sex distribution actually equalizes.
Oh, interesting.
Yeah. It is also exceptionally rare in the Far East and Africa. The one notable exception is Japan.
Right, Japan has a similar incidence to Northern Europe, but they present with a much milder form of the disease, right? Like very few contractures.
Precisely. Now, we know there is a strong hereditary disposition here. It's an autosomal dominant trait with variable penetrance.
Right.
And siblings of patients are over 3 times more likely to develop it.
But what actually sets it off? I mean, it sounds like genetics load the gun, but the environment pulls the trigger, like seeds waiting in the soil until a trauma or smoking waters them into sprouting.
That is a perfect way to think about it. The genetic predisposition is the foundation. Specifically, genes regulating collagen breakdown like superoxide dismutase and MMP3 are inhibited, while genes promoting collagen development are upregulated.
So the breakdown is blocked, and the building is put into overdrive.
Exactly. But you need that environmental trigger to kickstart the whole process. Population studies show smoking and heavy alcohol consumption significantly increase the risk.
As does previous trauma or surgery to the wind.
Yeah, exactly.
Now, systemic conditions like diabetes always seem to play a role in fibroproliferative issues. How does diabetes factor into Dupuytrens?
Diabetics absolutely get it more frequently, and type I diabetics are actually more prone than type 2.
Okay.
But here's the ironic twist you need to remember. Diabetics tend to get a milder form of the disease.
Wait, really? A milder form?
Yeah, they present with more nodules than severe contractures.
That's counterintuitive.
Okay.
Let's drill down into the actual biochemical mechanism when that environmental trigger is pulled. So if a Viking descendant smokes a cigarette and triggers this local ischemia, what is actually waking up inside the hand to cause all this damage?
It all comes down to microvascular angiopathy and local ischemia. So smoking, alcohol, and trauma, they exacerbate this microangiopathy,
Right.
causing the local tissue to basically become starved of oxygen. And the ischemic tissue releases free radicals. Think of those free radicals as a panic signal.
Like a biochemical alarm going off?
Exactly. They stimulate interleukin-1, which acts like a first responder sounding a broader alarm. That alarm triggers a massive release of growth factors, TGF-beta, FGF, EGF, and PDGF.
Okay, so a massive alphabet soup of growth factors.
Right, but you don't just need to memorize the alphabet soup here.
Yeah.
You need to understand that these growth factors are chemical megaphones screaming for the body's construction crew to show up and start building.
Which brings us to the micro-level battleground. That construction crew is the myofibroblast. This cell is the absolute primary culprit, right?
It is.
It's a bizarre hybrid sharing features of both a standard fibroblast, which builds tissue, and a smooth muscle cell, which contracts.
Exactly. And because of that panicked biochemical environment we just described, these hybrid myofibroblasts start producing the wrong type of structural scaffolding.
Normal palmar fascia is largely composed of type I collagen, right? Which is incredibly strong and stable.
Yes. But in Dupuytrens, the tissue is predominantly type 3 collagen.
Wait, so the body is essentially building the wrong, weaker type of scaffolding type 3 instead of type I, and then flexing it like a muscle because of these hybrid myofibroblasts.
That is exactly what is happening. The tissue is literally pulling itself together. This manifests clinically in two distinct forms, which are nodules and cords.
Okay, nodules and cords.
Nodules are the palpable subcutaneous lumps, usually fixed to the skin and the palmar fascia. Cords are the organized, relatively hypocellular collagen structures.
A helpful way to visualize this cellular shift for your exams is that healthy anatomy relies on flexible bands, but the disease hardens them into rigid cords. Just remember, B comes before C in the alphabet. Normal bands become diseased cords.
That's a great mnemonic.
But clinically, is one more active than the other? Like, are the nodules doing the pulling?
Well, what's fascinating here is how our understanding has evolved. It was traditionally taught that nodules were the active pulling component and cords were just the static, cellular end product of that contraction.
Like the debris left behind after a storm.
Right, exactly. But we now know that is incorrect. Dupuytrens is a mix of static and dynamic contractile elements found throughout the entire palmar and digital fascial system.
So they're both actively pulling?
Yes, both the nodules and the cords are actively involved in the contracture.
Okay, here's where it gets really interesting. Because to understand how this destroys hand function, we have to look at the macroscopic anatomy. How does the cellular mix-up alter the intricate 3D architecture of the palmar fascia?
To understand the pathology, you have to know the normal anatomy cold. Think of the palmar aponeurosis like a complex suspension bridge with 3 distinct layers.
Okay, layer 1.
First, the longitudinal fibers. This is a triangular layer that fans out into 4 protendinous bands. These bands have 3 layers of insertion.
Right.
A superficial insertion into the dermis via the grappo vertical fibers, a middle layer passing dorsal to the neurovascular bundles known as the spiral band of Gosset, and a deep insertion near the A1 pulley via the McGrowther fibers.
So when the disease hits those superficial grappo fibers, that is what causes the classic skin thickening and skin pitting we see in clinic, because the fascia is physically pulling the skin down.
Spot on. Then you have the vertical fibers, which consist of the septa of Legoux and Juvara. Diseased septa here can actually cause a painful trigger finger by impinging on the flexor tendons.
And the third layer.
Finally, the transverse fibers, which include Skug's ligament proximally and the natatory ligament distally. When the disease forms natatory cords, it pulls the fingers together, causing web space contractures.
But the real danger, the absolute terror for a junior surgeon, is the spiral cord. I mean, it sounds like the disease is essentially setting a booby trap.
Oh, it absolutely is.
By pulling the nerves and arteries out of their normal hiding spots and pushing them to the surface, it makes fixing the hand incredibly risky.
It is the definition of a surgical booby trap. In the fingers, the spiral cord originates from 4 distinct structures.
Which ones?
The middle layer of the protendinous band, the spiral band, the lateral digital sheet, and Grayson's ligament. Now, the spiral cord itself is actually straight.
Wait, I'm trying to visualize this spiral cord. If the cord itself is straight, how is it a spiral cord? Am I picturing the nerve wrapping around it like a vine on a trellis?
That is a very common point of confusion. The cord isn't spiraling. The nerve and artery are spiraling around the straight, contracted cord.
Oh, I see.
A more anatomically correct term would be spiral nerve and artery, because as the cord contracts and shortens, it pulls the neurovascular bundles, the NVBs, so they spiral medially and superficially.
Which is terrifying when you're making an incision.
Because of this severe anatomical distortion, there is a massive risk of iatrogenic neurovascular injury during surgery. You never ever cut directly onto a cord.
Right.
Skin incisions must be made carefully through the dermis only, and then you must ascertain the exact location of the NVBs through blunt dissection.
With the anatomy shifting so dangerously, are there any structures that the disease spares? Like landmarks a surgeon can actually rely on?
Yes, and this is highly relevant for your understanding of surgical safe zones. Skug's ligament in the transverse fibers of the palm is classically spared.
Okay, so that's a reliable landmark.
Exactly, making it a reliable landmark for the NVBs, which lie deep to it. In the digits, Cleland's ligaments, which run dorsal to the NVB from the phalanges to the skin, are also typically spared.
We shouldn't forget ectopic disease either. These rogue myofibroblasts can set up shop in other parts of the body.
Yeah, they really can. You can see Gerod's pads on the dorsum of the proximal interphalangeal joints, or PIPJs.
The middle knuckles.
Right. You can also see penile fibromatosis, known as Peyronie's disease, and plantar fibromatosis in the foot, known as Lederhose's disease.
So what does this all mean for the patient sitting in front of you? With the anatomy so distorted and the recurrence risk looming, how do we decide when to intervene? And how do we predict who is going to have an aggressive case?
Well, the clinical presentation is progressive flexion contracture, most commonly affecting the ring finger, followed by the little, middle, index, and thumb. To guide surgical intervention, we use Houston's tabletop test.
The tabletop test is elegantly simple. You ask the patient to place their hand palm down, completely flat on a table. If they cannot get the fingers flat, the test is positive.
Exactly.
But not all positive tests dictate the same urgency. Can you clarify why a PIPJ contracture, the middle knuckle getting stuck, is so much harder to recover from than base knuckle, the MCPJ?
It all comes down to joint mechanics. Mild flexion of the MCPJs is not an immediate indication for surgery.
Because the ligaments don't tighten up?
Right, because the MCPJ collateral ligaments are actually stretched when the joint is in a flexed position. They maintain their length, so they don't permanently shorten.
Oh, okay.
However, the PIPJ volar plate and capsule physically shorten when left in a flexed position.
Oh, wow. So they get stuck like that.
Over time, they contract permanently, resulting in a fixed flexion deformity that you cannot simply stretch back out. That is why a PIPJ contracture is a much stronger and more urgent indication for surgery.
And what about predicting the severity of the disease? We look at Dupuytrens diathesis, again proposed by Houston. There are 6 specific factors that predict an aggressive recurring course.
Yes. The 6 diathesis factors are bilateral palmar lesions, a family history of the disease, ectopic lesions, Northern European ethnicity, male sex, and an onset under 50 years of age.
Why does an onset under 50 years of age matter so much?
Because it indicates a highly aggressive systemic genetic penetrance rather than just a mild age-related wear and tear presentation. And the numbers on this diathesis are stark.
How stark?
If a patient has all 6 factors, they face a 71% recurrence risk after treatment.
Wow.
If they have 0 factors, that risk drops to just 23%.
Okay, so if we connect this to the bigger picture of management, we follow the British Society for Surgery of the Hand, or BSSH, guidelines. They classify the disease into mild, moderate, and severe. Let's break those down really quickly.
Sure.
Mild is essentially no functional problems, or an MCPJ contracture of less than 30 degrees. Management there is just observation. Moderate is when functional problems begin, or an MCPJ contracture between 30 and 60 degrees, and maybe a PIPJ contracture under 30 degrees.
For moderate disease, you consider non-surgical options like percutaneous needle fasciotomy for an isolated MCPJ contracture or collagenase injections. You might also consider a limited fasciectomy.
Severe disease is an MCPJ contracture over 60 degrees and a PIPJ contracture over 30 degrees. This pushes you toward limited fasciectomy or a dermal fasciectomy. Let's talk about the non-surgical tools first. Xipex or collagenase. How does an injection literally melt these thick, fibrous cords?
It's pretty wild. Xipex is a mixture of 2 specific enzymes extracted from the bacteria Clostridium histolyticum. When injected percutaneously directly into a single cord, these enzymes chemically digest and lyse the contracted type 3 collagen.
So they just eat the scaffolding.
Exactly. Then, 24 hours later, the patient returns, and you physically manipulate and extend the finger to rupture the chemically weakened cord.
That must feel strange for the patient. Does it work?
In the cord IN2 clinical trials, 77% of patients with MCPJ contractures achieved reduction to under 5 degrees, though success at the PIPJ was notably lower at 40%.
And what about percutaneous needle fasciotomy?
This involves using the bevel of a hypodermic needle to blindly cut the cord under local anesthetic. It has very low complication rates if you stay proximal to the distal palmar crease, avoiding the digital nerves, but the recurrence rate is incredibly high.
Like 85%, right?
Yeah, exactly, 85% at 5 years. It is essentially a stopgap measure.
Just to quickly rule out what doesn't work, so you don't waste time on exams or in clinic hand therapy, and splindage and isolation do not work. Radiotherapy, ultrasound, and calcium channel blockers are absolutely ineffective at reversing the contractures.
Absolutely.
So, when the tabletop test is failed and the disease is severe, we look at surgical options.
A limited fasciectomy is the most common operation. You are surgically removing just the macroscopically diseased fascia.
Right, so a limited fasciectomy is essentially just trimming the visible weeds above the surface, whereas a total or radical fasciectomy trying to dig up the entire garden to get every last root.
Which perfectly explains why total fasciectomy has fallen entirely out of favor.
It's too much digging.
Taking all the palmar and digital fascia, whether diseased or not, carries unacceptably high complication rates, and crucially, it doesn't actually prevent recurrence any better than just taking the diseased tissue.
And if the skin is heavily involved.
If the skin itself is heavily involved and tethered, we upgrade to a dermofasciectomy, which is a limited fasciectomy plus excision of the overlying skin, resurfaced with a full-thickness skin graft.
Let's talk about the skin closure, because there's a highly counterintuitive technique here.
Hmm.
You can use Brunner's zigzag incisions or Skoog's longitudinal midline volar incisions. But if you have a skin defect after releasing a severe contracture, you can use a graft or you can utilize the McCash open palm technique.
Right, the McCash technique.
Wait, you leave a 1.5 centimeter wound in the palm, completely open? How does that not invite a massive infection or create an even worse scar?
It sounds alarming, I know, but the palmar tissue has an exceptionally robust blood supply. By leaving transverse wounds up to 1.5 centimeters wide completely open in the palm, they heal remarkably well by secondary intention.
Just letting it fill in naturally.
Yes. But more importantly, leaving the wound open prevents hematoma formation. A hematoma in the hand is a disaster. It serves as a culture medium for infection and promotes severe postoperative scarring and stiffness.
Ah, so it's a pressure release valve.
The McCash technique avoids that entirely.
This raises an important question about outcomes. What is the difference between recurrence and extension?
Recurrence is the reappearance of Dupuytrens tissue within an area of previous surgery. Extension is the appearance of the disease in a new area not previously operated on.
So the disease just moves.
You must counsel patients that surgery does not cure the genetic predisposition. It only resets the mechanical clock. And complication rates overall are highest when correcting deformities greater than 60 degrees.
Releasing that stubborn PIPJ is still controversial, isn't it?
Highly controversial. There is no overwhelming consensus. Some surgeons advocate for sequential surgical release of the joint.
Starting with the check rein ligaments, right?
Yes, then the proximal volar plate, the accessory collateral ligaments, and finally the flexor tendon sheath.
That's a lot of cutting.
It is. Which is why others argue that aggressively operating on the joint capsule basically guarantees post-operative stiffness. They prefer to release the fascial cords only, relying on gentle, continuous passive extension post-op to slowly reclaim the joint mobility.
So to bring it all together, Dupuytrens is a bizarre journey. We start with Viking-linked genetic origins, add an environmental trigger like smoking or trauma that starves the tissue of oxygen, and watch as shape-shifting myofibroblasts lay down the wrong type of collagen.
It's a cascade.
You have to navigate the booby-trapped spiral cords that pull the neurovascular bundles into the danger zone. And we use everything from bacterial enzyme injections to the McCash open palm technique to fight back and restore function.
It requires a profound understanding of three-dimensional hand anatomy to navigate safely and treat effectively.
Absolutely. The next time you ask a patient to put their hand flat on a table, take a second to appreciate the complex orchestration of type I collagen and anatomical bands that make that simple pain-free movement possible. Thank you for joining us for this revision deep dive.
Yes, thank you.
If you found this high-yield session helpful for your FRCS prep, please press follow on the show so you don't miss our future breakdowns. Also, make sure to get a premium subscription to listen to our Journal Club and Clinical Cases episodes where we take these concepts even further. Finally, please leave a comment or a question below. We want to know what you're struggling with in your revision.
Good luck with your board exams.
But before we go, I want to leave you with one final provocative thought to mull over. If our bodies inherently possess the mechanism to transform regular cells into these muscle-like myofibroblasts to forcefully pull tissues together, a process that clearly goes haywire and destroys function in Dupuytrens, could unlocking the off switch for this very disease actually hold the secret to mastering scar-free tissue regeneration and wound healing in the rest of the body?